Firstly, I will acknowledge the traditional custodians of the land on which we live and work and of the many different nations across the wider Brisbane South region. We pay our respects to the elders, past, present and emerging, as the holders of the memories, the traditions, the culture and the spiritual well-being of the Aboriginal and Torres Strait Islander peoples across the nation. We acknowledge any sorry business that may be affecting the communities as a whole. In the spirit of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which responds to the needs and aspirations of the community. So firstly, I'd just like to do a little bit of housekeeping. All the participants here this evening are muted. We have quite a few registered to attend tonight, so we've got a big group. If you've got any questions, please pop your questions into the conversation box or the chat box, and we'll answer those as we go through the session tonight, and at the end of the session you'll have plenty of time to ask your questions and have them answered. Following this session in the next few days, we'll send out a survey to everybody, so keep an eye out for that and we would really appreciate your feedback. It helps us to improve our sessions, and any suggestions for further education would be greatly appreciated. So just one last thing, a couple of things. We do have a COVID support or COVID information on our website, the Brisbane South PHN website. If you are after information, COVID information, please go there and you'll soon find it. And if you've got any questions for COVID related questions, you can email questions to covidsupport@bsphn.org.au, and that email contact address is on our website as well. Tonight we've got myself, our presenter, which I'll introduce shortly, and I've also got Michelle Gordon. She's the practice, she manages the Practice Nurse Support Program for Brisbane South PHN. So some of you here tonight are probably participants of that program, and others, if you were interested in the program, you can have a look at also on our website at more information. The program supports nurses with education, mentoring, support, nurses who are new to general practice and new to the general practice role. We have a program that supports them. So you can find more information on the Practice Nurse Support page on the website, on our website. Right, I think that's about it from me. So I'm going to hand over now to our speaker for this evening, Marg Jennings. So Marg is a microbiologist and infection prevention and control consultant and educator. As a microbiologist, Margaret has worked in clinical and research, bacterial, viral, immunology laboratories, and has been a lecturer, tutor and demonstrator at a tertiary level. Margaret's interest in infection prevention and control started many years ago when she reviewed the use of chemical disinfectants in hospitals. So in 1994, the National Standard for Instrument Reprocessing was released, and that attracted her interest for its application for office-based practice. Now, that's infection prevention and control, and I guess, Margaret, in the last 12 months or more, COVID has probably taken over for you. But I'll let you introduce yourself more if you'd like to, and hand over to you. Thank you.
Thank you, Susan. I'll just get you to, how do I alter the screen? I've got a tiny tile here, and my eyesight, I need to make it bigger. How do we do that? Show participants.
You should you should be able to just maximise your screen.
No,
will that work if you maximise the screen?
No, I'm double left clicking. Just bear with me, everybody. It's just that I haven't got my glasses on. I see nothing. I can. Yeah, I've got you, Susan. I've got Sally Carsus in as a guest. She's the other half of your thing. So are you able to...
Sally, can you just turn off your camera?
She's got her camera off.
She
it's
has.
it's just her name.
Yep.
Okay. Yeah, I think you've got to switch something over to presenter.
Oh, sorry, Marg. Have I
That's
not
okay.
made you? Yep. Let me have a look.
Everybody knows what you're going through.
Wait a second. Yes, exactly. No, I think, Marg, you're already a presenter on my screen.
All right, I'll try
Let me
and
just check.
I'll turn the questions off.
Yes,
Yeah,
do that.
No, I've just got this tiny tile in the bottom right. Everybody else has got their name on, and I'm there. Just let me see if I can open the share tray. No, that doesn't work.
Marg, if you go along the top where you can see participants, conversation, etc., you'll see 3 small dots.
Yeah, got it. More actions.
If you go down to full screen, if you try that.
Enter full screen. No, that you came up with enter full screen. As I said, just give us a minute, everybody. Turn off incoming video. Turn off incoming video. Keypad, show background, enter full screen.
Try that.
No, that just makes you come up into the full. What I'm going to do is I'm just basically speaking to half a blank screen and you on the other side, Susan.
Okay.
So we'll
all right.
What can you
see? How we go. You're fine, Margaret. I can see you and we can hear you well. So you continue
now I've got
on.
Somebody else's face has popped up in my screen. I don't think I'm presenter. Somebody else I'm saying hello to. I think she might be lying in bed.
Helma. Hello, Helma. We can see you on the screen as well.
Yeah, she's that big.
Yep.
Right. Okay. So what I'll do is if you can adjust that, that'd be really good because I've got the feeling
how I go.
It's on your end, and I really can't do anything about it. All right. So everybody, my name's Margaret Jennings. Thanks for putting aside your Tuesday night. And what a week, what a fortnight. I'm in Melbourne, and there we go. Somebody's adjusted. I'm just speaking to a blank screen, so I presume that you can see me. Thinking about where you are with your cases today, that's piqued everybody's interest. You're probably beginning to get a bit stressed. I'm in Melbourne, and we're sick to death of it. So we've just come out of our, I don't really think what we went through in January and March were real lockdowns. This one's been a bit more of a lockdown, but we've kind of come out of it. So we went into it very quickly. We go into our lockdowns very quickly, and you guys do too. It's not a case of what you think, but the longer you wait, what happens is you're going to be having more cases at the end. So I know it's a drag, but until we've got herd immunity, this is the way it's going to be. End of story. What can I say about? I want to say something actually about airborne spread. So this is about your clinic, and this is what I want to tell you is what it's like. This is how this virus, this is how it really spreads. Of course it can spread. I'm close up to you and I'm talking to you, and the small droplets get onto your mouth, down the hatch. It's looking for your throat. All right, that's the target cell. Also the lungs, can be the eyes, can even be a bit of the gastrointestinal tract. So sure, being really close up, that's an effective way of spreading. Spending lots of time with that person. No masks, great way of spreading. But I'm going to tell you about a phenomena that could occur in your practice, and I don't want it to occur, but here is how we can do something about it. So this airborne spread. So I've just described droplet spread. You've all heard of contact spread. Can I just say one of the reasons why we wear masks is actually to stop you touching your mouth. Fantastic. Everybody's got beautiful long fingernails in Melbourne, and I'm sure you guys will too, because you can't bite your fingernails once you've got your mask on. So what I want to describe is this phenomena of I'm in a room that really hasn't got good ventilation. It doesn't have windows that open, the door's closed all day. And in that room are 2 or 3 people. And they may or may not have masks on. Let's say they've not got masks on. They're working in an office situation. There might be a bit of aircon or heating, whatever, but there's really no air exchange. You really do have to have 4 to 6 air exchanges at an hour to really move your cloud. So what happens is you speak, and the smaller particles, because there are all sorts of different particles that come out of your mouth, you know, they're bits of spit and snot, okay? I'll be blunt. And the big ones fall quickly. They're the big droplets. The smaller droplets a little bit further out or a bit further out. And then the tiny bits. The tiny bits of spit and snot dry off if the humidity is right, if the humidity is low. They dry off. Actually, there's not much difference with temperature, so don't get carried away saying it's worse in Melbourne because of winter. There's only about a 1% difference. So they dry off and they remain suspended. So they're carrying, all those bits are carrying the virus. But now you can see what happens. You're in this room, the air is reasonably still, and the cloud gathers. They stay suspended. It can be for hours. Okay, but even let's say it's an hour. Let's just say it's an hour, and you're coughing. And you're
excuse me, Marg.
Yep.
I've just got Sally. Sally, you have your hand up. Oh, it's gone now. She's and if you could fill in the chat box if you've got a question, Sally, or I can unmute you.
Yeah, can I just say it's Sally Carsis whose screen I'm looking at. It's green. It's all green.
Yeah,
so
I can see it.
Sally's got something happening that's stopping mine from me seeing myself. That's why I feel I'm in a room not talking to anybody.
Yeah. No, we can hear and see you very well, Marg.
Oh, that's a shame. All right. So can you see or feel or get that idea in your imagination as the more I talk, the more of those tiny particles just now start to gather. They accumulate. They're not settling, not for over a good hour or so at least. And that can be your patient in your waiting room. That can be you at work, unknowing that you have this virus. And so this really still air, not being changed, that is how airborne spread occurs. So I don't want that to happen at your practice, and I want you to see your patients, but I'm going to put it to you that we can do it a bit differently. And I'm not meaning everybody does telehealth. Like, I'm not talking about that. Sure, you can do an amount telehealth, but really this is what we should have been doing all year so that you were in excellent practice, because people would be bragging to me, I can't tell you, all last year, and, oh, you know, it's a shame you're down in Melbourne, Marg. And I'd be saying, listen, we are so good at this now. We don't have people in waiting rooms. Who's got a waiting room? No, they're outside in their car. And if they've got to come inside, they get called in just as it's time. So remember, it's time. The longer the time you spend, closer up, and can I just say 1.5 metres is just rubbish when you are in a room with no air exchange. Okay, so I know we all go on about social. I don't even like the word social. It's a bit antisocial, isn't it? Antisocial distancing. But that social distancing is not going to help you in that sort of a setup. So you're now thinking, gee, I'm the receptionist, you know, sitting at the front desk. And so this is what I've got to say to you. I've got to say to you, do you screen people before they come in? Do you screen other staff? And I don't mean just do a temperature check. Only about 45% of people are going to register a temperature anyway. So I'm talking about the responsibility that all of us have before we go to work each day. And you've actually got a responsibility to know what's going on in your household. And I'm talking about the 15-year-old in your house who lives in their cave. You've got to be able to say to them that you need to know as soon as they have any symptoms, because you'll be dragging them along to the testing clinic. Anybody who has any symptoms, and can I just say the symptoms have changed with Delta. We're not looking so much for loss of sense of smell or taste. That's pretty much, I think, about 29th on the list now, or it's way down. We're getting a younger cohort because they're not immunised so much, and it's really about it's runny nose stuff. It's runny nose, sore throat, headache. Fever's dropped, you know, gone down a bit. So we're seeing a different cohort, you know, younger group, and we're getting different symptoms. So, you know, if you think you're looking for breathlessness, that is not going to be up the top of the list like it was, you know, a year ago. So things have changed. The Delta variant is what I call a bit more sticky. Going to latch right onto that throat, the throat cells, target cells, lung, etc., etc. So it appears the incubation period is still about the same. We didn't know whether it was or it wasn't, but it looks that it's about the same. But yes, it's true. You can become positive really within a couple of days. You can even begin to get symptoms. We know it's, you know, 2 days to 14, 15 days. So here you are in your clinic and you're thinking, how am I going to run my clinic COVID safe? Because you thought you were. You thought it was enough to wipe over the doorknobs at lunchtime and again at 6 o'clock, and that everybody did their hands. And I know in Queensland, because I'm a frequent visitor, I know that you weren't wearing masks all year. I know that because I went to clinics and I was laughed at. They're not laughing now. And I said to my mum, I said, Mum, why aren't you wearing a clinic? Why aren't you wearing a mask? Oh, Marg, you're from Melbourne. Well, she's wearing a mask now, I can tell you. But it's a preventative. You don't wait for a case. You can't say that there are no cases. I mean, I look at every state 10 times a day, but for as long as we are receiving people, you know, citizens back into Australia, we will have COVID here, and until we've got herd immunity. Okay, so, and as the Chief Health Officer says, we're not safe until we're all safe. That's the situation, and I really want to lean in and say, get a grip. So how can we run our practice? Well, it's about when you get up. Am I checking, how do I feel? You know, any of those symptoms? And you're wanting a change too. You know what I mean? If you've always got a runny nose ever since the day you were born, you know, that's not it. Also, when you do get a COVID test, and yes, as soon as you have got one or more of those symptoms, you get a test. And even if it's negative, go back in a couple of days' time and get a second one. Okay? You can get, you know, false negatives, etc. It mightn't have gone back far enough in the throat. And most of us in Victoria have had 3 or 4 swabs over the last year. Okay, so people, I don't want to have a swab. Well, too bad. That tells us lots and lots and lots. The little kids, they can do the saliva test. Don't panic about that. There's a little bit of flu around too. I don't think they're doing panels of, you know, RSV and flu when they're doing the COVID test all the time. I just wish they would, because that would give us heaps of information, because then you'd actually know what it is you've got when they phone you up to say negative for COVID, or they text you negative for COVID. I think they phone you when it's a positive. Okay, so there you are, getting out of bed. No, you feel fine. But what about that 15-year-old in the room next door? You give them a hard time. You say to anybody in your household, you must tell me if you've got any symptoms. Because you know what? You shouldn't be at work. You're now going to be a close contact potentially. So you take the 15-year-old, you know, they've got symptoms, take them down to get a swab. It's the only thing to be doing with a 15-year-old. And, of course, the whole household stays home until the results are known. Anyway, but let's say everything's fine at your place and you're at work. Are you checking each other? And I'm serious. Are you checking each other? I can't believe it. You know, in Victoria, after the sort of, you know, last wave, people have a bit of a cough. They'll say, oh, no, it's just a bit of a cough. I can't believe how quickly they slipped back into it can't be COVID. And of course, you know, then we had our wave plus a cluster just recently. So how about making your workplace really safe? Check each other before you get inside. You know, do a buddy thing. Got any of these symptoms? And remember, it's not all about breathlessness and loss of sense of smell. It's a bit more about those pretty ordinary things. And you will hear yourself say, it couldn't be COVID. That's what you'll hear yourself say. And yet I can tell you that there were 2 clinics involved here in Melbourne, and they both had to spend thousands to get a deep clean and all that sort of stuff. Whereas if they hadn't run a waiting room, they would have been so much better off. So this is how you can work it. You can say, I've got windows and doors. Fantastic, open them. You can put a security screen on. I've got a waiting room, but you know what? I actually don't want people in here waiting and, you know, breathing, which they'll do, of course, all over my receptionist. How many receptionists have you got? Why have you got 2? not only can they never be 1.5 metres apart, they're going to be sharing that airspace behind their sneeze shields. You've got sneeze shields. So you see how we get a bit of it right and then we stuff up a bit. Are they wearing masks? I hope so, because you are working in a healthcare facility, not a coffee shop, okay? Although they're probably wearing them inside them as well. They are here anyway. So you're saying, I work in a healthcare facility and I need to keep my staff safe and I need to keep my patients safe. I'm going to keep seeing my patients. I've got to do that. We are, you know, it's critical. You're a part of the health system. So you go, windows are open, that's good. What else can we do? Well, at one of the clinics that I see, brilliant. It was an 8-doctor practice and they said, we're going out to the patient's car. Fine. And then they just sort of had a mask, on. And as the patients arrive, they would phone and the receptionist would say, just wait outside in your car. Doctor will come and see you, or the nurse will come and see you. Patient thought it was fantastic. One of the nurses was actually doing dressing on a patient's leg in the car. Fine. Okay, we can do that. Or chairs outside. Got a nice little shady spot? Have a few chairs. Outside is lower risk always. Now, when you go to see your patient, you want to see them privately. So you might have a little, you know, tent around the corner, or you might take them into the treatment room. If it's got a separate door, you can do that. And that's what they're doing at my clinic. They've actually got a back door to the treatment room, 3 cubicles, and you go in there to see the doctor or nurse. And for a bit of privacy, you get walked back to your car and there's a bit of a private chat and stuff like that. The doctors, can I just say, and the nurses where you've got your own room, doctors love it. They're not seeing patients in their consulting rooms. They don't have to wear masks now in their consulting rooms because they're on their own, doing a bit of telehealth and doing, you know, notes and everything. Coffee machine, you know, personal coffee machine. What's not to like about that? And the patients are getting seen in the treatment room with the back door open, and they're coming and going through there. The receptionists love it because the patients only literally just pop through to pay, which is all contactless. I don't think I've seen cash for about 18 months in Melbourne. So here are some of the things that we can do. Now you might say, I can't do that with every patient, but you can do it with a lot of patients. And the more you can do it, the less the risk. You can risk reduce. So even if tomorrow when you go into work and you go, yeah, what have we got all these stupid windows closed for? Open them. Door. Just have the security screen on if you don't want patients walking in all the time. You know, you can have a thing that says the door is locked because, give us a call. Not difficult. It's amazing the things. And the patients, can I just say, appreciate it. Oh, yes, because some of them will say, I wasn't sure about coming down and blah, blah, blah. And then, of course, you want to know before the patient even comes inside for anything, symptoms. So go through that. Don't just hold the temperature, the thermometer out and do their thingy. I think only about, 34% of elderly people are getting a temperature and about 45% overall. Now, that's about people who've got symptoms. What about people who don't have symptoms? And I've got to tell you, about 40% of people who are infectious are asymptomatic. They don't remain, not all of them remain asymptomatic, but about a half maybe will just never get symptoms. And that's very typical of viral infection. So you're really looking at people who might be in the pre-symptomatic phase, right? And then they will go on to get symptoms. And people get symptoms of different sorts of severity, you know that. Now, for a lot of people, they'll go, oh, really? Is that COVID? Is that really all it is? It was just like a terrible cold, although I think you've all seen pictures of the minister in New South Wales who's not feeling fantastic at all. And he's not an old bloke, he's pretty young. He's not feeling fantastic at all. But really the problem time is the second week. Okay. So, I think he's going to be okay. But what I need to tell you is always look at the numbers in hospitals. Now, in Queensland, it's very difficult for me to judge because you put all your positives in hospital. So I don't know how many are crook. Okay. In Victoria, New South Wales, have a look and then look at how many in ICU. So you'll start to see the ICU numbers trend up after a couple of weeks, and then the deaths will follow that. And I can't be any more blunt. Although we've become better at treating really sick patients in that second, third week, people do die, okay? That is why this is a problem. If people didn't die and it was just a bit of a sore throat, I don't think we'd be calling it a global pandemic of concern. But the fact is we've got a 1 to 2% mortality rate, and if we just let it rip, we would have a collapse of the health system. So you know that about 1 person in 5 is not flash, okay? And about 1 person in 10 can end up in hospital. Now, that would just be a collapse of the health system. That's why we're treating this seriously. And I kind of still have to remind people, and some people have had it, there are also 6 people in Melbourne who are in this really weird group of a year later still have symptoms and are still testing positive. Now, if you look at the World Health Organization, you know, criteria, we have to treat them as positive, and they're not old. Okay? And we don't know what to do with them, but they can't live with their families. Now, they're not even really the long haulers. The long haulers are people who are just struggling, you know, to get back to normal. So that's also an effect from this virus. So there you are sitting at your practice thinking, gee, I thought all I really had to do was, you know, do my hands, pop a mask on and clean the joint a couple of times a day. Believe you me, I want you to think about that cloud. How can we move it? We can move it by air exchange. So I'd be thrilled to bits if you went to work tomorrow and the windows got opened and stuff like that. I'd be really happy if, although you had to get close to a person to examine them, I'd be really happy if you had the privacy chat on the way back to the car, that we didn't stay close up to people unnecessarily, that we kept our windows open, that we saw people outside when we could. All of these things reduce risk. And we did these things in July and August last year in Melbourne. You can do them in Brisbane. Don't tell me it's been cold. I've seen people with gloves and scarves on up there in the presser each morning with the Premier. You reckon that's cold? All right, so the cloud. Now, I'm actually going to show you something about the masks, which is why I don't want you to get into that situation of airborne spread. But I'm actually just going to show you a, and you might have seen me do this last time, but I'll show you again. This is a surgical mask, was a surgical mask, all right? I cut it up a bit, and I just wanted to show you the 3 layers. So we like triple layer, okay, surgical masks. So you've got the front bit that just sort of, you know, stops all the big bits settling. But the real point of the surgical mask, of course, was to stop everything coming out onto the patient's, you know, surgical site. The inner bit's a bit softer, and the middle bit, it feels for all the world like skin, for a skin graft. Now, when we, excuse me, when we put this on, always do your hands, of course, before you put your mask on. Here's the nose bridge. About a third of the, I can't really see what I'm doing here, but a third of the way down the nose, form it. Don't have this great long gap like that. That is not good mask wearing. So on there. Now do not fold over. You want that as flat as you can get it, because what you want to do is breathe through this mask. You don't want somebody else's droplets and bits and pieces going in through the side. So nice and flat. And just a little tip, not that I can see that well, but do you see how I can put it on and they won't fog up? That won't fog up. But if you sort of start doing it like this or doing it like that, you'll get into all sorts of trouble. Now, the way to take it off, and can I just recommend change every 2 hours? I can hear the practice managers going like that, and I'll tell you why. So to take it off, it's 2 hands away and down. The only place for a mask that's been removed is not your glove box, it's the bin, okay? So into the bin. Now, with this mask, you can see that if I have airborne, you know, this cloud, this is not as effective. It's good while people are maybe moving through super quickly and stuff like that, and droplets. You know, big droplets, great. But where I've got this cloud, and you'll see the hospitals are doing this, they'll use what we call the P2 respirator mask. And so here I've got electrostatic forces at work in the multiple layers, and you'll see the fitting is quite different. So I'm just going to show you how to fit check it, not fit test, fit check just in case you're in a position where you might need to do it. But remember, I don't actually want you to have to use these because I want you to avoid the cloud. All right, and I think I've described how we do that. So again, do your hands first. Here you can see the bands. So you get your beak in. And if you had hair like mine, you might wear a head cap. It's up to you. You don't have to. It's just to keep everything out of the way. So this is the bit with the nose bridge. And I, again, about a third of the way down the nose, I form that and I come around here and I do a bit of a yawn to fit it better. Now I do some heavy breathing. And oh, I can feel a little bit of warm air there. So I readjust. Bit of heavy breathing. Yeah, good. Can you see it collapse? Well, that means I'm breathing through the mask. All right, I'm actually breathing through it. There's no air coming in at the side. Here, there's a little bit coming in. We don't want it to, but this is my P2 respirator. Now, what I have shown you there is called a fit check. But to use these to gold standard, you would, get hold of the hospital and say, we want to send a couple of staff along to be fit tested for P2 masks. Now, of course, I've said that and they'll probably call me tomorrow and say, retract that statement. But the only way to use these to the correct standard is to have them fit tested. And what they do is these people have a special machine, they're special operators, and they can tell whether there's any little leak. I've done a fairly crude one, but that's what they do. So I don't mind you having a few of these in your, not in your back pocket, but in your cupboard for an emergency. But it would be an inside thing, or where I've actually got to go inside the patient's car. Not sort of seeing the patient like that, but inside the patient's car, and they're really sick with respiratory symptoms, I'd be going for one of these. Now, to take it off, so one's on the crown, one's below the ear. To take it off, grasp two and away and down, okay? And that's how, and into the bin. These, I would just put these on for that one patient where looks like I've got to stick my head in and see a really sick person with respiratory symptoms. I'd be a little bit keener to give myself that sort of protection. So when I'm mixing with other people in the practice, I'm wearing this mask. I suggest it every 2 hours, and I'll tell you why. Firstly, when they get wet, they don't work. I don't know about you, but huffing and puffing up and down the hills here, because we had to wear masks outside up till recently, they get wet. So they just stop working. Also, I'm thinking of your mental health. Of course, can I just say, anytime you touch it, you've actually got to, do your hands, all the, palaver. But I'm thinking of going to the toilet, having something to drink, and just getting the stupid thing off and standing outside for a few minutes or whatever, wherever you can be where you don't have to wear it. I think that's really important. So it goes into the bin. You go to the loo, you have a drink, and you've had, that 5 minutes of a good manager would be tapping you on the shoulder saying, I think it's time for a bit of a stretch, a bit of a something. Going back to my receptionist, I mentioned that I'm not keen for them to be, in the same space for obvious reasons. And you might say, oh, isn't that sort of being a bit silly? Well, I've just put it to you. As I said, 2 clinics in Melbourne got sort of pinged week before last. So not only, because they had a patient in there who was positive. They had the patient in there who was positive. Couldn't believe it. So, yeah, you've got to close down, wait your time. You're all, considered varying levels of contact and thousands, for your deep clean. But if you arrange your clinic to be absolutely low risk, my hunch is you can argue a bit with the health department and say, but we do this, we only see the patients in that room, or we go to the car, we don't have anybody who's symptomatic in the clinic, we see them outside, we wear our surgical masks, seeing the patients. Can I say you can wear this for more than one patient? We call that extended use. Obviously, if it gets splashed or you touch it, you've got to change it. So I would want to see my staff wearing at least 3 fresh masks a day. I wouldn't be pushing it. Theoretically, you can wear them for 4 hours, but I just think that's ridiculous. So I'm sorry if I, doubled the cost in your practice, but we really do want people to be wearing these correctly. None of the what I call the tracheotomy look. So none of that. Or what about the mouth breather? No. Okay, so it's got to cover your mouth and nose. So that was, I think, a few tips. Now what I'm going to do is try to see if we can see the conversation. Has anybody got any questions? Oh, that's Sally saying, not sure how I got on camera. Well, don't worry about it, Sally. We've moved on, and I think Sue just read that out. Any questions come up there, Sue?
There's no questions as yet, but please add your questions to the conversation box or the chat box if you have some questions for Margaret.
Okay, so let's just talk now a little bit about the vaccine. And you're going to say, I'll try and preempt here, is the vaccine effective against the Delta strain? And I've got some information for you. It's been, what do they say, in plain view. And I knew about it a few days ago, but it's now they're saying it. So you heard about the big party of 30, well, not very big, but a party of 30 people at Hoxton Park in Sydney Southwest. And I spoke to them a couple of nights ago. 30 people at the party, 24 positive. There you go. The person who spread that did a fabulous job. So you see, not everybody spreads it to other people, but some people really spread it, the super spreaders. So 24 people out of 30 ended up, but 6 didn't. And I'll tell you who the 6 were. They were healthcare workers who were all immunised. You liking that? Now that is really, it's not bad evidence. I'm a scientist. I'd like to see N being a little bit higher than, 30 and 6, but that's not bad. That's giving us some confidence. Now, those figures were already arriving from the UK. And we do have some evidence, and now we have, I think, get stronger evidence that, yes, the vaccine we've got, the AZ and the Pfizer, it's hot. Well, they're probably younger people, probably got Pfizer, but I don't know that. But can I just sort of do a bit of a plug here for AZ? I think that the AZ is a very good vaccine. And my bet is that over time, it may even be shown to be superior. One of the things they did with the AZ, and there was a bit of a stuff up with the way they measured the antibodies, which worked for everybody's favour. But with the AZ, people were still, their antibody levels were still rising when they stopped the trial, which is pretty good, Now, be ready for some surprises over the next few weeks. Now, you needn't sort of send me $1,000 for this bet, but depending on how the cases go around Australia in the next week or so, don't be surprised if you see not a 12-week gap for the 2 AZ shots. And I know those of you who are running immunisation clinics are just going to die when I say this, but I think they might pull it back to 6 weeks if we get a few more cases, okay? So that that means people get a nice prime in their immune response. As long as there's more than 4 weeks between the first and second shot of AZ, it'll be fine. It's just that we know that you're still getting those nice antibodies being produced months and months and months later. So there's one thing that may happen, and I know you're all thinking, oh my God, how we manage. But bringing it back to 6 weeks means we can actually give people fuller immunity, because what we know about the AZ and the Pfizer is that if you've only had 1 shot, you only get about a 33% protection, and it's when you get that second shot that you get much higher. So we're looking at sort of 85. I mean, people whinge about, oh, it's only 88% and the other's 95. I mean, that's fantastic. So anything really over 70% is pretty good. In fact, World Health is saying anything over 51% we'll take. And it's been a highly scrutinised, group of vaccines with 2 billion doses taken, probably more scrutinised than anything I received in the 1950s, I can tell you. So interesting enough, people aren't talking about clots so much now that there is an outbreak on. Nothing sort of focuses the brain and self-interest as a few cases, but also, I don't know whether you know, but they're getting on to explaining what to look for with the clots, and they're getting a whole lot better at treating them. So yes, these have been the early days of that, but I tell you what, although the AZ, they're talking about phasing it out here, I wouldn't be so sure. I wouldn't be so sure. And can I say, they had no trouble getting any buyers for the AZ that Australia's making. So, you know, just sort of hold the faith there. But yes, every vaccine has side effects. I mean, with the Pfizer, I think they had an increase in myocarditis in the younger blokes. It wasn't fatal, but it was, you know, it's recognised. So with the two main vaccines that you've heard about, the AstraZeneca is what we call it's a viral vector. So that means they've actually used a virus, an adenovirus, but it's from a chimp. If they used a human adenovirus, your body would just go and gobble it all up, and your immune system wouldn't get a chance to look at what was inside it, which is actually the code for the virus. So they've actually put the code for the virus into the adeno. Adeno is a DNA virus. So they've put the code in, and what happens is they inject the virus into you, and you go, oh, so do I get like a monkey virus in me? And the answer is yes, but it is unable to replicate in your cells. That's the way it's sorted. So it latches onto your cell, and it gets in and it puts the antigen, or the code, starts to make your cells produce these little bits of spike protein. Then your immune cells come along and say, we don't like this stuff, and they start producing antibodies and T cells against that. So that's a viral vector, gets into your cells, and then your cells recognise that as you know, they're producing it. What happens with viral infection is that your body doesn't actually know that it's being infected. In those first few days that COVID gets into your throat cells, it switches your cells on into making more viral particles, and your throat cells don't know that that is foreign until, of course, it bursts out of the cell and you start to get your sore throat. So by putting this little bit of code for spike protein, which is the vaccine, the AstraZeneca, delivered to your cells make antibodies to the spike protein. And the spike protein, the antibodies we make, we call them neutralising antibodies. And so they stop the virus from latching onto your throat. That's what you want. So you have antibodies, and you make T cells. In fact, their response is more cell mediated than antibody mediated to COVID. Now, the messenger RNA, which a lot of you will have received, is, and you know, got to keep it cold, not as cold as what we thought. And I know that some of the GPs are going to be given the messenger RNA to give, so they don't have to sort of worry about these incredibly cold, you know, situations. It's sort of become a little bit easier to manage. We're learning about it. And so here, the messenger RNA actually, again, directs your cells into making spike protein. Your body then says, spike protein, this looks like an antigen to me, and makes antibodies and T cells against it. Now, the most important thing about the vaccine is not what happens in the first week after you've had it, because what happens in that first day or two, and all of you guys would have had it, I've had it, either vaccine, you go the next day, oh, I did a really big session at the gym yesterday, you know, a bit achy. This is part of your innate immune response, and that is your body says, I've just been bombarded with an antigen, I don't like it, and I've got a few cells and a few, you know, bits and pieces in the armoury to fight it, and you feel a bit lousy. Can be even interferon. Okay, it's a very non-specific reaction in that day or two. About 20-25% of people are feeling something, you know, the next day. But about 12 to 14 days after you've had your first shot, something else happens. And that is your antibodies start to rise. And this is called your adaptive immune system. This is what we're really after. We're after the antibodies and the T cells. start to, become suppressor, killer, all that kind of thing. And of course, remember I said if people get into strife with this, it's usually in the second week because your T cells go a bit stupid and cause an incredible inflammatory reaction. That's what gets people into strife. So in that second week, I've got antibodies coming up, but unfortunately not really protective. If you were exposed to the virus 2 weeks after your first shot, no, sorry, I don't think you're going to get much protection from it at all. But with the antibodies being produced, they're produced by plasma cells, there's another type of cell that gets produced, and this is what we want. We want immunity. That means, should I ever be exposed to this virus again, hopefully, not, then my plasma cells that have become memory cells will go into action and produce antibody levels like this within about 24, 48 hours. And I'll never know that I've been exposed to COVID a second time. I mean, next year. So that is not just the immune response of antibodies, they're a bit useless, can I say, because I got better. So the antibodies rise, people go, well, what's the point of all that? They're really high at 8 weeks, but I'm better. Well, one of the reasons why you do get better is also because the antibodies are rising. But the other reason is that we need you to be producing your memory cells. And so your memory can be T cell or B cell, could be antibody or cell mediated. That comes into action the next time you're exposed to this virus. If you like, even your second shot, if you like, is a way of provoking memory. And that's why you don't tend to get, those things a second time. Now, what else can I talk about? Vaccine hesitancy. Oh, there's not a lot of it around at present. Believe you me, a bit of a cluster here and there, and the lines just started to fill up again. So whereas I was going to talk about vaccine hesitancy, this is why I think Australians were a bit vaccine hesitant, and it's because the virus was just not there in front of us. Like, why should I even take this risk when we don't have cases? Well, you know what? That was a month ago. And things are looking very different now. And I'm not quite sure how it's going to pan out. You can say that we went in too early, we went in too late. I'm a huge believer in going in very early, very, very early. With New South Wales, okay, you can have fabulous tracking, contact tracing, but you've got to be ahead. I think they might just be getting ahead of the virus now in New South Wales, just. But it was exponential, the growth was exponential last week in New South Wales. So let's see how we go. So I don't think there's too much hesitancy, but be gentle with people to a degree. Then you can get snappy with them. I'm not talking about that they're not anti-vaxxers. They're just, I don't know about this. I don't know about it. And of course, you would have heard the other bit of news that came through today that AstraZeneca can be offered with discussion to people under 40, and I think that is a very sensible thing because you've got to look at where we are. We risk, with no herd immunity, with 5% of people or less fully immunised, we risk a massive outbreak here, massive. And then there'll be no talk about clots because people will have wanted the vaccine 3 months ago. So here's the situation that we're in. We didn't see a lot of cases over the last few months, and we become a little bit more, we're okay. Very natural human thing. It's a little bit like taking precautions. Why should I wear a mask? We haven't got any cases. Well, you do now. And it was actually last week that we needed to be wearing them. So, just wear them automatically every time you're inside. This thing about you can only have 50 people to your house, I'm shocked, because for the last year and a half, the one thing that we haven't been doing is having huge social functions. And yes, it's awful. And I mean, I had a grandson born last February and basically didn't touch him till about October last year. So, and that's really tough. I think I cuddled him in February when he was born. So here are these little COVID babies being born. They recognise you with or without your mask. And then, the 4-year-olds who remind you to do your hands. So going back to the vaccine, it's about saying to people, well, the clots, we've had 850 deaths in Australia. That really, I think, sharpens 3 deaths from clots, which is awful. But as I said, we're getting better at managing those clots. And I noticed too that when people are advised, you know, they're given all that sort of stuff. I think with the anti-vaxxers, you're just going to get nowhere. But if we can get, 90% of our population immunised with an 80% effective vaccine, that's really good. Just going back to the spike protein, the spike, there's the spike, okay, 3D printer type of a virus. The protein, the spike protein, is the reason why the vaccine is working against the Delta is that part, there's a part of the spike protein that is conserved. In other words, every time the virus mutates, that little bit is conserved, which means that any vaccine made to the spike protein, will be effective in some way or another. Not as effective, it may not be as effective, the Delta strain, the vaccine to the Delta strain, but it is holding, it's holding, and that's what we really want to hear. I mean, there are dozens of vaccines in the pipeline at present, and who's to say that what we start with, that we'll finish with. Now, I was going to mention one surprise, which is it wouldn't surprise me if they pulled back the gap to 6 weeks because of the cases. The other thing that wouldn't surprise me if you might start off with Pfizer and end up with AZ, or start with AZ and end up in your second dose with Pfizer. Just sort of bear that in mind, that actually might happen, because they're both wanting you to produce antibodies to the spike protein. So they're the two main sorts of vaccines. The other ones are whole virus, which killed virus, but really they're just not as antigenic. And I know that there are a couple of them around, but I just don't think that they're going to be as good. People go, why didn't we order more Pfizer? Well, we had to sort of put our order in last year, and you can bet on 20 horses, or you can bet on 3 horses, you can bet on 50 horses. So that's just the way it is. I sort of wouldn't be belly aching too much. I know people get really antsy, but it is what it is. With quarantine, I have to say quarantine is a very human endeavour, and it is hard. I have not been with, but I know somebody who was in quarantine, and the 14 days is just rubbish. And she sort of got to know every crack in the wallpaper, etc., etc. The food was rubbish because it had to be delivered pre-packaged. So it was, donuts for breakfast, pies for lunch. Pretty awful. Everybody's hanging their hat on Howard Springs. I will hold my own counsel, but you will get breaches all the time. It's about whether a breach turns into a case, transmission. With our recent outbreak in Melbourne, it actually came from Adelaide. The poor bloke he was leaving quarantine, and he's picked it up as he's left. So South Australia apologised very nicely to us, but the poor bloke, he was on the plane, flew into Melbourne. About 3 days later, 4 days, I've got a sore throat. This is ridiculous. I've just done 14 days quarantine. Bit of a sore throat. So he did the right thing. Went and got a throat swab. Positive. And it's evident because he was negative on day 14. His clearance swab was negative, and his other ones had all been negative. With you guys, the guy from Bendigo came to share the same hotel on his way to the mines, and that's started the outbreak in the Northern Territory. With the Northern Territory, I'm very nervous because of we've got a lot of comorbidities in our Indigenous population as well, and I see that Arnhem Land has closed itself off day before yesterday, so nobody is allowed into Arnhem Land on tours or anything like that at present. And I think we've got a real duty there, because if it gets into the Aboriginal population with the comorbidities, there will be a higher death rate. And I know they've been immunising madly, but people feel that same hesitancy. But I'm in a community and there's no COVID. Why should I have the vaccine? Very human, reaction until there's a case. And unfortunately, can I say, the wrong time to immunise is during an outbreak. You just don't get bang for your bucks there. You immunise between waves, and that's what we should have been doing. Okay, the for the last 6 months. Should have been immunising madly. So let's see if we get some changes there, whether we get a mix of vaccines as our 2 doses. Not mixed together, but, you know, one there and the other one there. And let's see if we get that shorter gap. What else might happen? Already AstraZeneca have got have given the license to change the next vaccine. The next COVID vaccine will be pivoted to the variants. So you can do that. It takes a little while for that sort of vaccine. With the messenger RNA vaccines, they can alter them to the variants within 6 weeks, which is pretty amazing. So although it's a sort of a new platform, the messenger RNA technology, we've had billions of people given that. And certainly AstraZeneca, I don't think we've seen the end of it. Now, I'm just sort of going to look at the time, and I'm thinking, I'm going to put to you a thought, and I've been wrong. Well, no, I won't say I'm wrong, but at this point it hasn't played out. Here was my concern. My concern was New Guinea would be the means of would cause an outbreak in Queensland. I was convinced, and I liaised a bit with the lady in North Queensland, the PHM there, and she said, you know, she's from Saibai Island in the Torres Strait. She can see the Papua New Guinea mainland 4 kilometres. That's all there is between the Torres Strait and New Guinea. And New Guinea is in a bad way. Don't take any notice of the figures that you see coming out of New Guinea. There's way not enough testing. So I was convinced, because she said the people come over in their motorboats and trade with Saibai all the time. So I was convinced that it would get into Queensland. So that was, you know, at this point it doesn't seem like it, but we shall see. Now, I think just going back to your practice, what things are you going to do tomorrow? Okay, it's going to be counterintuitive because you can't see this thing, and you're going to say, is it really here? I feel a bit stupid wearing a mask. Well, nobody feels stupid wearing a mask anymore. We're so used to it. But it's a preventative. Much easier to do that than do none of it and say, I'll wait till I've got a case, because by the time you've got a case, you've got more than one case. Okay, and we can never say that you just had 3 in Brisbane today. You can't say that, because that was just the people who came forward for testing. And in fact, that was who came forward yesterday. You can't say how many cases that you've got today. Neither can you say, oh, we'll do something when we've got 100 cases, because the virus doesn't behave like that. So, you know, one person spreads to another. It's doubling. It's not just adding one. It's doubling. It's exponential, the way it goes. So I was going to stop there. And, oh, I know, you can't have too much alcohol in life. So I was going to show you just with the hand, started to wear my wedding band again. But there, below the elbows, no jewellery. Much easier to do hand hygiene, and it'll be much more effective. So nails, you know, not above the back of the finger, etc., etc. Put in a bit of a swimming pool. Fingers in, get it into your fingernails, into that one. Spread. I'm saying this because I see the way people do it. All glistening wet. Now rub it in, because you need 20 wet seconds. That's how much you need on your hands. 20 wet seconds to knock off this little critter. But if you keep rubbing, okay, sticky, just going soft now. But if you go like this, one hand, 2 drops, all dry in 5 seconds, you've not killed anything. So I'd really like to see people do hand hygiene a bit better. Don't forget to look after your skin. Hand cream 2 to 4 times a day. Put it on before you start work. It's a barrier cream, all right? You just use the same brand as what you're using for your alcohol, and put that on before you start work. Do it a couple more times during the day. But if you can wear your masks properly, as I said, look, the 1.5 metres is a joke when you're inside. Don't have waiting rooms inside. And think about, how can I reduce it? Think of the stress. Would the doctors be better off seeing their patients in a mixture of telehealth, in cars, and, you know, in a tent or a marquee or in the treatment room. But think about them having their own consulting room as that, wow, you know, that little place where they can be, you know, have their coffee and relaxing. Because I don't know, if I was a doctor, of patients coming into my room all day long with masks on, what are they touching and are they doing their hands, etc. But have a think about the way you organise reception. When you're wiping your high touch surfaces, if you're using a detergent disinfectant, you identify, people should be able to do their own, but they are touched, shared, high touch surfaces, light switches, door handles, blah, 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 blah. So I usually get about 4 surfaces out of one wipe, just fold it over each time, fold it over, do the other, just wipe out, leave it wet, leave it nice and wet. And you need, this will give you about a 4 log reduction, even after about a minute. So a wet minute, fine. With chairs, honestly, just where the patient touches it. Now, one of the vaccination clinics, they've put the wipes and they've said to the patient, when it's your turn and you've got to get up, wipe the hand, you know, if you've got armrests, wipe those, or the back of the chair. I'm not really worried about the rest of the chair unless people have got bare skin against the chair. But that's something you can ask people to do. But otherwise, I would just say, why are people even sitting in my waiting room? Not interested. Why have we got armrests? Not interested. So think about how you can reduce all of that stuff, which is work and money and time and risk. How about we just reduce risk? All right, I think that's enough from me.
That's great, Margaret. Thank you. And I'm just looking in the chat box. We don't have any questions, so you must have answered everybody's questions.
I don't know.
But we've probably got a minute or so. If anyone would like to quickly type in a last-minute question, we'll just give you a minute or two. So thanks so much, Margaret, for all of that information and that discussion tonight about various topics around COVID and how we can continue to reduce the infection prevention and control that infection possibilities and things to, I guess it's always a good reminder, you know, to keep it in the back of our mind, you know, what we need to do day by day. So no questions coming up yet.
No,
okay.
I'd be happy if people just thought about 2 or 3 things they can do tomorrow to further reduce risk. Don't panic about doing everything that I said, fabulous if you can, but just think about how you can pivot a bit more. And are you doing things that absolutely are high risk? You know, like being inside in the tea room and all right next to each other and all that kind of thing. I just don't, you know, have an outside chair and table. It's beautiful weather, you know, do it.
So would anyone like to provide us with what you're going to take away from tonight and go and put in place tomorrow? Has anyone got any thoughts about that? Quickly type those into the chat box. That'd be great.
Windows and doors, see patients outside in cars or patients wait outside. Better alcohol hand washing, yes, absolutely. You've really got to knock that virus off from your hands. And when you remove your gloves, one little trick, I still see this not being done correctly, but always do your hands after you've taken your gloves off. Yeah, about 30% of the time that you take your gloves off, you'll have the patient's bugs on your hands. Always do your hands. So to take your gloves off, it's grasp, off, grab, thumb underneath, over the top, hands. So you see people pick, no. So, you know, all those nurses, they'll know how to do this. They can teach everybody else.
That's right. That's great. Okay. All right. Well, we might finish it there, Margaret. One. There you go. Another one. Can you see that one? No patients in the waiting room.
Yes.
Review that situation.
Just make life safer for everybody. And just don't tell me it's cold up there.
No, we've got beautiful days. We've had beautiful winter days out here, so it's lovely to be outside.
Yeah, no, it's been lovely here too. 16 and sunny as. Gorgeous. We don't mind.
Perfect.
All right.
Perfect. Okay, thank you so much again, Margaret, and thank you everybody for joining us this evening, and we will see you next time. Thank you so much, Margaret.
Thank you. Bye.
Bye.